Good afternoon, everybody. It's my pleasure and honor to be part of these prestigious rosters of speakers in this important international symposium on bone marrow failure disorders. My thanks to Dr. Bijou George for organizing this important meeting and inviting me for the second time. My title today is Immunosuppressive Therapy versus Upfront Alternate Donor Transplant in Children with Aplastic Anemia. And these are the topics we will go through. I will discuss the most important study related to immunosuppression, and then I will discuss the study with immunosuppression with the addition of eltrombopag in childhood. Then we will go through the match-unrelated donor hematopoietic stem cell transplantation option, and then finally the haplo option, which is becoming more and more fashionable in aplastic anemia in children. This slide illustrates the outcome of a very classical study conducted in different countries, in different continents, in different times, and it shows clearly that the overall survival, which is obtainable in children with aplastic anemia with this type of treatment, is about 90%. When it comes to evaluate the quality of this survival, so assessing the event-free survival, which is a qualitative indicator, data coming from this very classical study from the EBMT, severe aplastic anemia working party of the BM3, shows that event-free survival declines down to 33 or 37%, thus meaning that about 2/3 of children and adolescents survive with life limitations in terms of quality of life. This finding has been confirmed by this another important EBMT study. Andrea Tichelli is the PI, in which the long-term outcome of patients receiving classical immunosuppression, which is ATG plus cyclosporine A with or without G-CSF, well, the outcome in the long term, 15 years follow-up, shows that the event-free survival declines down to 24 and 23% with no differences regarding the use of G-CSF, and importantly, related to the topic of my talk, with no differences between adult and children. This finding of the limited event-free survival after immunosuppression in children has been confirmed by other studies. This is from the colleagues from the North America Pediatric Aplastic Anemia Consortium, in which only 1/5% of the response were complete. And this is the findings from the colleague from Asia, in which only 1/3 of the responses were complete. When it comes to look at the malignant clonal evolution, after immunosuppression in children, based on the different findings coming from different studies, it can range from 8 to 21% at 10-15 years if we look at MDS and AML. We know that this kind of event is more frequent in patients who do not respond to immunosuppression and in those receiving multiple courses of immunosuppression. Just as a comparison, I would like to point out that malignant clonal evolution in the EBMT survey ran on the adolescents was lower, 1%, but recently an important study ran by the Seattle group, which was focused on a little bit higher age population because the median age was 21.1, pointed out that the cumulative incidence of cancer in this cohort was a follow-up of over 25 years is 11%, which is twofold more than US general population rate expectation, with 53 cancers, mostly non-melanoma skin cancers, strongly associated with GVHD, and only 4 of them being hematological. Then eltrombopag came, and I'm happy to quote this important study from the NIH group, from the group of Neil. Neil Townsley was the first author, in which was prospectively tested the chance of getting better outcome by including eltrombopag in addition to ATG and cyclosporine A. There were 3 cohorts in this study, and one, cohort 3, the one in which eltrombopag was given from the very first day, had the best results with an overall an overall response rate of 94% and a complete response at 6 months of 58%, but in this cohort, less than 20% of patients were accountable for pediatric age. Then it was the RACE study, which is conducted by the severe aplastic anemia of the BMT with my friends and colleague Regis Pefol-de-Latour and Antonio Risitano being the PI, which was a randomized controlled trial, which included 205 treatment-naive patients coming from 6 nations and treated in 26 centers, randomized for receiving Altgam plus cyclosporin A, arm A, or Altgam plus cyclosporin A, arm B. And these are the main findings. You see that at 3 months, the red column indicates the overall response rate, which is significantly higher in the arm B, that with the thrombopag. And the same applies for the complete response, which is significantly high, 22% over about 10% in the thrombopag arm versus the non-thrombopag arm. Similar finding was reproduced with higher figures at 6 months. But the point to be raised is that out of 205 patients which were enrolled, only 9 were pediatric patients aged between 15 and 18 years. So we cannot consider this finding as valid for the pediatric age. What we can consider valid for pediatric age is this study from the NIH, again from the group of Neil, Emma Groark was the first name, in which 40 evaluable patients in whom inherited bone marrow failure was excluded were tested prospectively and compared with historically matched control. You see that for each of the 5 endpoints of this study, overall survival, event-free survival, overall response rate, complete response, relapse, and clonal revolution, there were no significant difference in terms of outcome when we compare the arm with a thrombopag with that with only immunosuppression with no thrombopag. Suggesting that, different from adults, in children does not seem to be a benefit by adding a thrombopag to the classical immunosuppression. Similar findings came also from this smaller study from the group of Marcin Włodarski in Memphis. Although there was an advantage for the thrombopag arm for overall response and complete response and event-free survival, as shown by the plot here, that was not statistically significant. Many reasons can be called for explaining why a thrombopag, in addition to classical immunosuppression, works in adults and does not seem to work the same in children. One may be related to the type of diagnosis and the diagnostic tools we can use for in children with a marrow failure. This is a study coming from our group. Maurizio Miano is the PI, and out of 97 patients followed up with marrow failure in our centers, 54 were evaluated for being idiopathic, possibly idiopathic, I would say. 28 were confirmed as having classical constitutional marrow failure, Fanconi, telomere, Schwarzman diamond, Blackfan diamond, but 17% were found to have a concealed PID or PIRD, so primary immune deficiency or primary immune dysregulation, with various genes involved, GATA2, TACI, CARD, ligase, SECRIL1, PI3K, etc. But importantly, in the cluster of the idiopathic marrow failure, 41 patients show clinical biological findings of immune dysregulation, thus suggesting that marrow failure may conceal a primary immune deficiency or dysregulation, and that these genes have to be looked for in the genetic diagnostic workup for marrow failure, because they may enable targeted treatments, a more accurate family donor selection, and of course a targeted conditioning regimen. Now let's move to the match-unrelated donor section. This is the very first study, which is the classical one coming from the pediatric bone marrow transplant group of the United Kingdom, in which 29 patients were evaluated and matched with historical controls, transplanted all from match-unrelated donor. The outcome in terms of overall survival and event-free survival was excellent, and it compared well in terms of overall survival with immunosuppression, but it compared much more favorably as compared to IST in the event-free survival, thus mirroring what we have seen in one of the first slides of this talk. Acute GVHD and chronic GVHD were reasonable, 10% the acute, 17.2 the chronic, but all skin and limited. pointing to the fact again that there was a better quality of life, at least in the short term, with match-unrelated donor transplant over immunosuppression. Other studies came and confirmed that finding, in which you see that in terms of overall survival, the frontline transplant did better than frontline immunosuppression, and the same occurred also for a failure-free survival. Rather low value of acute GVHD and non-negligible figure for chronic GVHD. Recently, the severe aplastic anemia of the BMT reconsidered the outcome of a larger number of match-unrelated donor transplant patient transplanted upfront with this kind of donor, and 17 patients, median age 20, overall survival at 2 years, 89%, graft rejection failure free survival 86%, pointing that there is a very high proportion of subjects who has high probabilities of having a good quality of life because they live without rejection and without graft versus host disease that is not important, is not beneficial for the disease outcome in aplastic anemia. The acute GVHD rate was acceptably low. Only 2 patients had grade 3 and 4, and the chronic was 17, in line with the UK study, but with no extensive cases. So basically, all these findings seems to suggest that match-unrelated donor transplant is better than immunosuppression frontline, but actually all these studies were not the top of evidence level, and they were not formally comparative studies. So in the sense there was no prospective randomized controlled trial assessing the outcome of these 2 options. Well, this issue has been faced by the colleague from the United States, Mike Pulsifer was the PI, and in a study which aimed to assess whether it was feasible to conduct a prospective randomized controlled trial comparing immunosuppression and match-unrelated donor transplant in children. And in this study, 67 patients were screened, aged all below 25. 57 were confirmed having a true severe aplastic anemia, and the age was a little bit lower. 23, 40%, consented to the randomization and were treated with a median follow-up of 18 months. The diagnosed interval treatment for the immunosuppression arm was 36 days, whereas for the transplant arm was 7 days. 10 out of 12 randomized patients for the transplant arm actually received this treatment for a figure of 83%, which is far higher than the hypothesized 60%. Thus meaning that the primary endpoint of this study was achieved. And with this figure of randomization rate, we can predict that it is possible to enroll about 50 new patients a year diagnosed with SAA under the age of 18, meaning that we will have 200 patients in 3-4 years to participate in this study. Thus meaning that the study is feasible, but with some difficulties and probably in a relatively long time span. The outcome was not one of the aim of the study, but I think it's important to have a look at that. Small numbers, of course, and I said this is not the main endpoint of the study, but if you look at the rate of success and the failures, it looks like that hematopoietic stem cell transplantation works better than immunosuppression frontline. So basically, we can say that this prospective study is feasible, is not easy to do, but we have also to consider that there's another player who came into the scene, and this is Upfront. And that's what we're going to discuss in the next slide. This is the pivotal study coming from the Baltimore group, in which 37 severe aplastic anemia patients, 20 with relapsed refractory form, 17 with treatment-naive form, were treated. Median age 25 years, median follow-up 36. That's the scheme of conditioning regimen. As for the outcome, graft failure 11%, proportionally more highly represented in the treatment-naive cohort over the relapsed refractory when the radiation was TBI 200 centigrade. When the irradiation rate was increased to 400, none of the 10 patients who received that regimen actually experienced graft failure. The overall survival of patients in this study is 94% at 2 years. the rate of acute GVHD to 4 is 11%, the chronic GVHD is 8%, the graft versus host free survival is very high, and interestingly, the overall survival of patients with refractory relapse forms is higher than that of treatment naive, and all patients with a refractory relapse form are alive with no GVHD. So the issue of the graft failure that was higher in treatment-naive patients led the group of Baltimore to increase the TBI from the initial 200 to the 400 that are nowadays used. That enabled durable engraftment with no greater early toxicity. We don't know what about a long-term toxicity because, of course, the follow-up does not enable that. Another important finding is that similar outcome was seen in 10 SAA patients which received the identical non-myeloablative conditioning regimen with PTCY with matched donor transplant, so that conditioning regimen was not used only in the Upfront but also in the match-unrelated donors, pointing to the fact that this kind of conditioning may be used also in treatment-naive patients with this disease. The question is still open. There is a prospective control trial ongoing comparing haplo versus match-unrelated donor transplant frontline for newly diagnosed pediatric patients with SAA. Haplo has been investigated also in other countries. This is the BMT study. Pedro Prata is the first name, again from the Severe Aplastic Anemia Working Party. 36 patients, retrospective analysis, mostly pre-treated, acute GVHD 26%, although no grade 4, chronic 17, which seems to be quite in line with the finding we have seen around in this presentation. Follow-up 24.6 months, overall survival 74%, graft versus zone rejection free survival 58%. And the conclusion at that point in time was that it was an option where no other treatment are possible, but I think that currently the statement cannot be valid for any case. The Chinese were pioneering the option of the haplo, and out of the many studies they ran, I decided to illustrate this one because of the size, 101 patients refractory to immunosuppression. The study was prospective multicenter, busulfan, cyclophosphamide, rabbit ATG in the conditioning regimen. The graft source, as in Chinese centers, is bone marrow plus GCSF stimulated peripheral blood stem cells to overcome the barrier of the HLA, GHD prophylaxis, cyclosporin, mycophenolate, and short-term methotrexate. That's the outcome for GVHD, which is strongly in favor of matched family donor as comparison versus the haplo. You see 34% versus 4, 22% versus 6. But when it comes to look at the survival and the failure-free survival, it seems that these two options fare very similarly with no statistical difference. The Brazilians conducted another study in patients who had the transplant after immunosuppression, which is this is another large study. Conditioning was flu, Psi, TBI, and after a number of patients, TBI and Psi were increased, most bone marrow failure as a source, graft failure 15%, acute 14%, but chronic 9%, which is probably one of the lowest value we have seen with this platform in which post-transplant cyclophosphamide is used. CMV reactivation 62%, overall survival at 2 years 79%, event-free survival 70%, but better outcome in patient receiving increased intensity conditioning regimen, flu, higher dose of cyclophosphamide or higher dose of irradiation, and patient receiving a higher amount of CD34 cells. We know that in Upfront it's very important to have the donors with no HLA donor-specific antibodies, and of course that was reflected in terms of lower event-free survival also in this cohort. Well, that was the last slide regarding the haplo. I think that based on the finding we have gone through in this presentation, we can say that in children at the moment, immunosuppression either with or without the addition of eltrombopag up front can be an option in a number of rather limited number of cases, particularly those in whom a donor cannot be found. When it comes to match-unrelated donor transplant frontline, in young patients, this is a reality in Europe, which is widely used as a frontline in many, many centers. Haplo is very much competitive with match-unrelated donor in the second line because of easier donor accessibility and lower costs. As for the use of Haplo in frontline, I think it is very appealing. We know that centers tend to do that because of the reason of much easier accessibility to the donor. But I think that further confirmation needed for putting that in the algo in a top position. And I think that the ongoing study, which I mentioned before, comparing Haplo versus MUD transplant for newly diagnosed SIA in children, can provide a significant and important answer to this relevant question. My thanks lie to my friends and colleagues, Regis and Antonio, in severe plastic anemia of VBNT. We've been working together for so many years. It's such fruitful and productive cooperation. Andrea Bacigalupo also is a good friend with whom I collaborate very easily. A number of international colleagues with whom we have exchange of ideas, of a project, of crosstalk, of scientific contents. Neil Young, Carmen Bonfim, Daniel Townsley, Phil Scheinberg, Rodrigo Calado, Parinda Mehta, my close friend Bijou George, and of course I'm happy we shall presented also here in this snaps. Of course, I'm greatly in that with the hematology unit in our institution, and of course to the patients and their family. Thank you very much for your attention.